The second most important shape or type of infection or bone infection or even septic arthritis is the tuberculous infection. Usually, we have three types of mycobacterium, either tuberculosis or bovis or africanum, which are acid-fast bacilli, and they need a long period of incubation to have the culture results. Usually, this mycobacterium reaches the patient or the organism by respiratory infection, or even sometimes in bowel infection or intestinitis. The bone infection appears in 1 to 8% of cases from respiratory infection cases. And the vertebral column infection counts about 30 to 50% of cases of bone infection. Usually, sometimes we have soft tissue and synovial tissue infection. Tuberculous infection is not the infection of healthy people or healthy patients. They come usually with bad general situation, bad living conditions, overcrowded areas, malnutrition, diabetes mellitus, old age people, or other predisposing factors that deteriorate or lower the patient defenses. Usually we have tuberculous granuloma that contains of epithelial cells and Langerhans giant cells surrounded by leaf cells. And we have which has usually cold abscess and casein necrosis, which is the characteristics of tuberculous infection. We may have three types of infection in the musculoskeletal system, either bone infection. Usually it's a haematogenous spread infection, and usually it affects vertebral bodies and long bones. The pus, we have a large amount of pus and casein formation that can cause increased tissue pressure and cell death and rapid cell death. Usually it's a chronic infection of bony tissue. This casein substance may calcify and appears on radiographs and may spread usually to nearby tissue. Articular infection either by direct or haematogenous contamination way. Usually have synovitis, marked synovitis that can cause the panos formation. This panos can cover, this is the hypertrophic synovium that which covers the articular cartilage and cause destruction of this cartilage and bone edge erosions. We may have also multiple loose bodies which resembles rice grains, and we have a severe and concomitant or bone degenerative changes or degeneration in both sides of the knee. That means the lateral and the medial articulation. In soft tissue, we may have cold abscesses, which they are not hot. We do not have local heat or local tenderness. But if they are super infection by germs, they may become hot. But usually, cold abscesses, they are cold. They are not very painful, and they may have discharges of casein substances. The symptoms of the patient which has the tuberculous infection are chronic or subacute pain, because the tuberculous infection usually is chronic situation. And we have in articular symptoms we may have pain, swelling, stiffness, disability, and marked muscular atrophy. We will talk about this. We may have a well-defined lymphadenopathy, and the presence of cold abscesses in up to 50% of cases, and skin sinuses in 15% of cases. The general symptoms are the symptoms of tuberculous infection, as pain, anorexia, loss of weight, night sweat, and mild pyrexia. Usually, the osteomyelitis, tuberculous osteomyelitis, resembles the chronic osteomyelitis, but it is usually more chronic. Laboratory tests, they are not specific. Mild elevation of ESR, white blood count, mild elevation with a mild increase of lymphocytes, and inflammatory anemia because it's chronic situation, and inflammatory the aspiration of inflammatory synovial fluid. We may have indicators of infection, of joint infection. If we do a tuberculin test, it's positive in up to 80% of cases, but unless we have immunodeficiency in this patient, we should be worried about this. The characteristics in laboratory tests are that the diagnostic procedure, to diagnose tuberculouss, we should identify the germ or the bacilli, acid-fast bacilli. We have two difficulties, or we should pay attention that we should always direct the investigator or the physician in the laboratory, that we should not take gram stain, but we should use Zell-Nielsen dye or Zell-Nielsen stain to identify this acid-fast bacilli. This is first idea. The second idea, the culture should be done using Stevens ginseng, Liechtenstein ginseng medias, and this incubation should last for 3 weeks to have bacterial growth or bacilli growth. We may also identify from tracheal lavage or mucus secretions to identify the bacilli. So it's not an easy way to diagnose the infectious tuberculous infection. Recently, we may use the PCR technique or the ELISA, using ELISA technique by identifying the antibodies as KDA 38, KDA 16. On X-ray examination, we see, as we see here in these radiographs, we see juxta-articular osteopenia because of the hyperemia that exists with the infectious arthritis. The cavities on the margin and erosions on the articular margins, symmetric joint space narrowing, osteolytic lesions, as we see here, ring bell sign that indicates to the presence of sequestra inside the cavity of osteolysis, and a spina ventosa that appears in the long bones, especially in hands or in the small long bones, as in the phalanges in the hands. Bone scan, MRI, CT scan are useful in studying this case, to have differential diagnosis, to plan the operation, and to determine how can we approach this situation surgically. Be aware, and you should put in mind that long history of pain and swelling, involvement of one joint, marked synovial thickening, severe muscle wasting, and enlarged regional lymph nodes with periarticular osteoporosis on X-ray, and additionally, positive Mantox test, we should suspect always tuberculous infection. So the patient may be presented or may present with pain, swelling, lymphadenopathy, muscle wasting, and regional lymphadenopathy, as I have said. On X-ray, we may have, if we have synovitis or septic arthritis, osteoporosis, periarticular osteoporosis. We should suspect the presence of tuberculous infection, and we should demand Mantox test or tuberculosis test that may assure the diagnosis. The medical treatment is a difficult treatment because it may have a recombination of many antibiotic drugs, specific anti-tuberculous drug, as isoniazid, rifampicin, ethambutol, pyrazinamide, and streptomycin. Usually we use this combination for 2 months. Then we continue for 4 months with isoniazid, rifampicin for 4 more months. And sometimes it may last for even 1 year, especially in the spine. The healing or the end of treatment usually is laboratory and clinical, and sometimes the radiological changes, they may last for longer time. As an infection, suppurative measures as splints to reduce deformity and make some physiotherapy and reduce pain. But we should always avoid intra-articular cortisone injection because it decreases the immunity of the patient and increase the infection of the articulation or of the joint. Surgical treatment usually is synovectomy, curettage of the lesion, bone grafting of the cavities, and articular resection, and even some kind of arthrodesis and amputation. But usually we do not do joint replacement in case of joint infection. Pott's disease, it's a special case of tuberculous infection in the vertebral column. We have 2 types of vertebral tuberculosis infection. Either spondylitis, that is infection of the vertebral body, or spondylodiscitis, that's infection of the vertebral body and the intervertebral disc. And the 2 conditions may coexist. The most common site of vertebral infection is the thoracolumbar junction. Clinically, we have, as we see here in this severe case of Pott's disease or vertebral infection, is the anterior vertebral collapse, body collapse or prolapse that causes angular kyphosis. And we may have some kind of compressive neurological signs because of the granulation tissue or called abscesses, because of the spinal stenosis, because of this deformity of the posterior wall of the vertebra, because the release of sequestra, bone sequestra in the vertebral column, and because of the vertebral instability, vertebral local kyphosis, and the venous thrombosis, and that cause neurological ischemia. So the vertebral tuberculosis is very important situations that we should identify and treat because it may cause neurological deficiencies. Usually the pain is at the site of infection, and we have angular kyphosis because of the wedge-shaped anterior prolapse or collapse of the body, of the vertebral body. And sometimes we may have some kind of cold abscesses that may reach the skin, either anteriorly like the hernia, inguinal area, or in the petit triangle at the back over the iliac crest. Radiological signs are usually significant by wedging the deformity of the vertebral body because of this collapse, or if we have discitis, we may have this reduced in the intervertebral disc height. But the use of MRI or CT scan is very important to diagnose this situation correctly. Because of these osteolytic lesions and or this osteolysis because of this infection, we may have this wicked-eyed owl sign. In normal radiograph, we may have the pedicles that resemble the eyes of the owl, and the spine of the vertebra that resemble the nose or the beak of the owl. If we have wicked-eyed like this indicates that we have osteolytic lesions and the absence of this pedicle. The absence of any one of these traits indicates the presence of osteolytic lesions, and we should note this very carefully because it may indicate the presence of tuberculosis, of vertebral tuberculosis, or vertebral tumor. The aim of the treatment of spinal infection by tuberculosis is to treat the infection and to alleviate the neurological signs and symptoms and to prevent this deformity. We should always, if we have a large abscess called abscess around the vertebra, we should make a drainage and continue with antibiotic therapy for a long time. That may continue up to 1 year. It's longer than the normal bone infection or osteomyelitis, tuberculous osteomyelitis. And we should treat this angular deformity because of the bony collapse in the vertebral body by arthrodesis, either by posterior or anterior and posterior arthrodesis or spinal fusion. And this is very important to do, and by this we come to the end of our first chapter or first topic in orthopedic surgery for the 5th year medical students. I hope that this will be beneficial for you. You can increase your hearing ability to English medical language. And we shall continue step by step by putting more and more English lectures on my YouTube channel. Thank you for your attention and have a good day and good luck, my dear students.